Ladies and gentlemen, thank you for standing by and welcome to the New York State Contact Tracing Initiative Training Series. At this time, all participants are in a listen-only mode. We will have a question and answer session at the end of today's presentation. You may submit questions via the Q&A panel on the right-hand side of your screen at any time during today's presentation. Simply type your question in the open area and click Submit. If you require any further assistance, you may press *0. With that, I would now like to hand the conference over to your first speaker, Ms. Julia Easton. Thank you, and please go ahead.
Thank you. Good afternoon and welcome. Today's training topic is communication challenges when you may not be able to speak to a contact directly. And we're pleased to welcome our trainer today, Jonathan Carmel from New York State Department of Health's Division of Legal Affairs. Jonathan Carmel has worked as an attorney for the New York State Department of Health since 2000. He has helped the department implement HIPAA policy and the state's Family Healthcare Decisions Act. He helps the department and members of the public with advance directives, healthcare proxies, do not resuscitate orders, and other medical orders for life-sustaining treatment, otherwise known as MOLST. He provides legal advice to the AIDS Institute on ending the AIDS epidemic and hepatitis C elimination, and he worked with the Division of Epidemiology during the recent measles outbreak. His areas of expertise include healthcare decision-making and the use and disclosure of confidential health information by public health agencies. And with that, I'd like to turn it over to Jonathan. Thanks.
Hello, this is Jonathan Carmel, and thank you for that introduction. I'm really honored to speak to you all today. This is a great topic, and you're welcome to put questions in the chat box as I'm speaking. With that, I will get started. So today we're going to try to get a very brief handle on the law for healthcare decision-making and by the individual, him or herself, as well as when it is appropriate to speak to a legal guardian or somebody who's a healthcare agent under a healthcare proxy or a surrogate under the Family Healthcare Decisions Act, or in other cases, an immediate family member or a close friend or other member of the household. So we're going to try to understand the role that individuals other than the contact may have when you're trying to get on the phone with the contact. And then finally, we're going to try to understand well, let's see, 3 is pretty similar to 2, but I'll read it. Understand how to effectively manage contact tracing when you may have to work with someone other than the contact. Okay, next slide. So we divided this presentation into 4 sections. The laws. Number 2 is working with someone other than the contact. Number 3 is similar to number 2, but it gets into it in a little bit more detail and talks about some specific examples. And then number 4 is the case where the contact is a minor. So the contact might be capable of talking to you, but it's not appropriate necessarily to talk to a minor. So we'll talk a little bit about that. Next slide. Okay, so first section is the laws for medical decision-making. Yep, you can go to the next slide. Thank you. Okay, so you've all heard the term legal guardian, and there's really 2 main kinds of legal guardians. Legal guardian is somebody who speaks on behalf of another person. So you all know that in the second bullet point, children have parents who are their legal guardians, or sometimes they have another person who's not their biological parent who's their legal guardian. And, you know, obviously if it's someone who's 6 years old, their parent or legal guardian is going to speak for them. We'll talk about this more later, but if it's someone who's 16 or 17 years old, they might be speaking for themselves or other, mature adolescents. And then in addition to that, in the third bullet point, adults can also have guardians. So if somebody loses their ability to take care of their own affairs, they might have a guardian appointed. And so you're all familiar with that term as well. So if someone has a legal guardian, in most cases, that's who you're going to be talking to, not the contact themselves. Okay, next slide. So this is the law for healthcare decision-making, and this is really just by way of introduction or to give you a conceptual framework. And the reason I say that is that the contacts are not making healthcare decisions. You're not a healthcare provider. You're not providing them with medical treatment, and they're not making healthcare decisions. So these are rules that are relevant in order to provide some context for the way that we think about decision-making in New York State, but these are not literally the rules because the contacts are not making healthcare decisions. And we'll talk about this more later, but what we're doing here is public health practice. You're not a healthcare provider providing treatment. You're working for the New York State Department of Health doing public health work, which is slightly different. Nevertheless, I'm going to go over some of these rules for healthcare decision-making. So in most cases, a patient makes decisions for themselves. Provided that someone is 18 years or older and they have the capacity to make decisions, meaning they have the ability to make their own decisions, which is typically the case, then, they're making their own decisions. And that's true for anyone 18 and older, and that's also true for somebody who's 102 years old. The assumption is that adults make their own decisions. So you would need some reason to stray from that assumption. The assumption is that people make their own decisions. There are cases where people can't make their own decisions, and for that reason, when people do have the ability to think ahead to the future, they will often create a document that's called a healthcare proxy, and under the healthcare proxy, the person signing it, the patient, is called the principal, and the person who they appoint to make decisions for them, if they're not able to make decisions for themselves, is called the agent. A lot of times people call the healthcare agent the healthcare proxy. That doesn't really matter. That's just semantics. But technically, the healthcare proxy is the document. The healthcare agent is the person who is making decisions for the patient if they lose capacity. The term capacity just basically means the ability to make decisions, but the second bullet point has the legal definition of capacity. If somebody does not have a healthcare proxy, since 2010, we have a law in New York State that's called the Family Healthcare Decisions Act, and it provides clear legal authority for somebody to make healthcare decisions when the patient doesn't have capacity and they also have not signed a healthcare proxy. And the people who make those decisions are the people that you would think make those decisions. It's a list that's in the law, and the first person on the list is the spouse or domestic partner, assuming the person isn't legally separated or divorced. And then, after that, there's a list which is immediate family members. So, your parents, and if your parents aren't available, it's your siblings. If your siblings aren't available, your adult children or whatever. Actually, I think I got that order wrong, but it's your immediate family. And then even if you don't have any immediate family, the law in New York State since 2010, the Family Healthcare Decisions Act, allows a, quote, close friend, unquote, to make decisions for you. So there really is the possibility in New York State for any member of that household who picks up the phone potentially to make decisions for the contact. And so that's what it says in the last bullet point. The surrogate may be an immediate family member or a close friend. Okay, next slide. So this is section 2. Keep going. All right, so how does what I'm saying apply to what you all are doing as contact tracers? So I already said what's in the first bullet point. The first section of this presentation was really just for background, but it's not the actual rules that you have to follow because you're not medical providers providing healthcare, and the contacts are not making healthcare decisions. Rather, we're doing public health practice, and we're not providing treatment to the contacts. What we're doing is trying to protect the health and safety of everybody in New York State. We're trying to prevent people from getting sick. We're trying to prevent people from dying. It's population health, not providing treatment to individuals. So it might be a little bit different from what you all are used to if you have experience in with healthcare providers, because some of you, I'm sure, have worked for doctors' offices or hospitals or nursing homes or whatever. This is a little different. We're the government and we're doing public health. We're not healthcare providers. So in the second bullet point, it makes that point again that what we're doing is public health and protecting the population. And so the end here, and I'll get into this more on the next slide, is to say that HIPAA actually does not apply to us as a public health agency. So we're a public health agency. We're not a healthcare provider or a health plan. And so HIPAA is not applicable, and we do not have to follow the rules of HIPAA. But nevertheless, I still want to talk a little bit more about HIPAA, and I'll do that on the next slide. Okay, so some of you are probably already a little bit confused by what I'm saying because you were hired as contact tracers, you've been going to all of these trainings, and as part of that, you've received HIPAA training, and you've been told HIPAA, 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 here's all of the rules of HIPAA. So let me just try to explain this. It's not that simple, but it's also not that complicated. So we'll get through this. So HIPAA applies to covered entities, and covered entities are healthcare providers and health plans. So the New York State Department of Health as a whole actually is a HIPAA covered entity. The reason that we're a HIPAA covered entity is that we operate healthcare providers. We have a hospital and we have 4 nursing homes. We also operate health plans. The biggest one that we operate is the Medicaid program. So the New York State Department of Health is a HIPAA covered entity. However, we have exercised the option that we are allowed to exercise under HIPAA to designate ourselves as a HIPAA hybrid entity. So what we have done is we have said that the hospital and 4 nursing homes that we operate are HIPAA covered. The Medicaid program and other public health plans that we operate are HIPAA covered, but the rest of the department is not HIPAA covered. And there's a very good reason for us to do that. HIPAA itself has a provision that states that public health agencies are not covered by HIPAA. And within the rules of HIPAA, it's allowed for a healthcare provider or a health plan to disclose protected health information to a public health agency as required or authorized by the laws of that state, and that's permitted under HIPAA. Once that disclosure is made to a public health agency, then the applicable law is the state law of that state. The reason for that is that in our system of government, public health is a function of states. It's not a function of the federal government. So New York State has existed since before the federal government existed. We were one of the original 13 colonies, and New York State has always had the power to regulate and to protect the health and safety of people in New York State. We do that under what is called the police power. So the police power includes the police, but it also includes us as a public health agency. We might have to quarantine people. We might mandate that people get vaccines even though they don't want to in order to attend school. And sometimes our public health power can be pretty extraordinary. We can restrict people and, kind of sort of imprison them in their homes, just like the police. But we're not doing it because they've done anything wrong. We're doing it because we don't want them to spread communicable diseases. And it's to protect the health and safety of people in New York. That's the police power. And HIPAA recognizes that the state of New York has the police power. And once disclosure of protected health information is made to us here at the New York State Department of Health, it's governed by state law. So I don't want to tell you that you should throw all your HIPAA training out the window, however, because it's still relevant. What you should take away from your HIPAA training is that you should only be using and disclosing health information as necessary to do your job as a contact tracer. So the HIPAA training is good because you're not supposed to be disclosing health information outside the scope of what you're doing as a contact tracer. It's possible that just by coincidence, you know a contact personally. Well, if you do, then you shouldn't be gossiping about that person with your friends. You shouldn't be taking that information or using that information outside of your job. If you had access to systems where you could look up somebody that you know personally because you have a personal interest in finding out if they're a contact or if they've been exposed to COVID, that's a big no-no. You can't do that. So HIPAA is relevant in the sense that you absolutely have to keep this information confidential and not use or disclose it outside the scope of your job as a contact tracer. However, as a contact tracer, when you're doing your job to try to protect the health and safety of people in New York, to try to prevent people from getting sick and dying, HIPAA is not applicable. What's applicable is state law. And so under state law, do you have to keep the information confidential? Absolutely. You don't disclose the information more than you need to in order to do the job of contact tracing. But if you're doing the job of contact tracing in good faith, and that's your intention, and that's what you're trying to do, then go ahead and use and disclose the information. That's what you're supposed to be doing. Don't worry about HIPAA. And don't say, oh, I can't, disclose the information to the contact's uncle because of HIPAA. No, if you need to disclose the information to the contact's uncle because that's what you need to do in order to do the job of contact tracing, then go ahead and do it and don't worry about HIPAA. So, but I still want to talk a little bit more about HIPAA just to say that, HIPAA provides some good rules because it's a nationwide standard. It's very well thought out. And it provides some very good rules just about how to protect confidentiality in general. And so even though those laws don't apply to you and you're not going to get in trouble for breaking those laws, those rules that are in HIPAA are still good to talk about because they provide some good rules for the road about how to handle confidential information. So in the second bullet point here, I wrote, though not applicable, HIPAA note that under HIPAA, information can be shared with the person involved in the patient's healthcare. So think about a patient who's in the hospital, and since they're in the hospital, lying in a bed, and they're very sick, they don't have the best ability in the world to navigate the complexity of being in the hospital and making decisions, talking to all the doctors, talking to all the nurses, doing everything that's involved. They're sick. They might be elderly. They might be confused. They might be, just waking up from general anesthesia, right? So when you're in the hospital, you've got your loved ones, hopefully, who are there helping you. The people who are in the room with you, your spouse, your adult children, your sibling, your best friend, whoever that person is, and you've invited them into the hospital room to help you. That's why they're there. They're your visitors in the hospital. HIPAA has rules about that. What HIPAA says, and the reason I'm talking about this is that it's kind of analogous or comparable to the person who are in the contact's household. If the person is picking up the phone because they're in the contact's household, there's a pretty good chance that that's a person who is somehow, intimately linked to the contact and is involved in their care. That's why I'm talking about HIPAA, not because you have to follow the rules of HIPAA, but rather because HIPAA has some rules about this that are just pretty good rules of the road to follow. So the third bullet point here is that under HIPAA, what it says for these, visitors in the hospital, when you're lying in your hospital bed, if the patient is present, obtain the patient's verbal agreement and give the patient the opportunity to object, right? So you say to the patient who's lying in the hospital bed, is it okay if I talk to your husband? 99 times out of 100, the patient's going to say, yeah, of course, yes, please. He doesn't have to leave the room. Go ahead, keep talking, right? And if the patient is not present, exercise professional judgment, determine whether the disclosure is in the best interest of the patient using experience with common practice to make reasonable inferences of the patient's best interests. So, even if HIPAA were applicable, HIPAA actually says it's okay to talk to somebody other than the patient who's involved in the patient's care. So we are adopting similar rules for contact tracing, and I'll get to those in a moment. Next slide. Okay, so working with someone other than the contact. Here's some examples of what might happen when you try to talk on the telephone with a contact. The contact might pick up the phone, and for whatever reason, they don't want to talk to you, and they would prefer that you talk to somebody else who's going to speak for them or listen for them on their behalf. So could you please talk to my daughter? Here she is. Bam, that's all you need. Talk to the daughter. The contact gave you permission to talk to somebody else. Talk to the other person. That's good enough. You're good to go. Do it. All right, 2 and 3 are a little bit more difficult. Number 2, a person other than the contact answers the telephone and they say, oh, the contact is my mother and I'm her agent under a healthcare proxy. So that's another situation. We'll talk about that in a minute. That's still pretty easy because of the way they're talking about it. You could probably just rely on that statement. Number 3 is a little bit harder. It's just the person who says, who the hell are you? Why are you calling me? No, I'm not going to put them on the phone. What do you want? I'll talk to you, right? I'm sure you've experienced that probably already. That's the more difficult situation. That's where you're going to have to exercise your professional judgment, and we'll talk about that some more. Okay, next slide. All right, so when someone other than the contact answers the telephone and tells you they are involved in the person's care, as I already said, you try to get the contact on the phone. If you can get the contact on the phone, either because they are the ones who answered the phone or whoever answered the phone puts them on the phone, if they say it's okay to talk to somebody else, then you can talk to somebody else. Second bullet point. Whenever we've just adopted this as a rule of to follow, just to as a way of verifying that the person you're talking to really does know the contact well enough. Make sure that the person you're talking to knows the contact's name, date of birth, and address. That's just a way to bare minimum of due diligence to make sure that this person you're talking to really does have a connection to the contact. And so you should do that in all cases. Okay, so if the person who you're talking to says these words that I've been talking about, they say, oh, The contact is confused. They have a healthcare proxy, and I'm their healthcare proxy. That's probably what they'll say. They probably won't use the technically correct term and say, I'm their healthcare agent under the document that's called a healthcare proxy. They'll probably just say, I'm their healthcare proxy. That's good enough. Or if they're familiar with the Family Healthcare Decisions Act, they might say, oh, well, I'm the spouse, I'm the domestic partner, we live together, which is the same thing. Or they might say, that's my mom, that's my dad, and if they're over 18, that's good enough. Or, that's my brother, that's my sister. You're talking about an immediate family member, somebody who lives in the household, and they've said that they are the healthcare agent or that they're the surrogate under the Family Healthcare Decisions Act. That if they use those terms, you should just rely on that representation and talk to them. But in all cases, this is the third bullet point, you're using your professional judgment to determine whether the risk of breaching confidentiality of the contact is warranted in order to accomplish the work that you're doing, which is preventing people from getting very sick and dying. So there's a balancing act that we're doing here. Is confidentiality important? Yes, it's very important. But preventing people from getting sick and dying, preventing New York from being in the same situation that Texas and Florida and other states are in right now is really important. And there could be a couple of broken eggs on the way, a couple of breaches of confidentiality on the way, but that's okay, because that's what happens when you do public health work. That's what happens when you end epidemics, when you squash, disease outbreaks, when you deal with a global pandemic. You might have to invade someone's privacy a little bit in order to deal with the situation, and that's okay. We'll get through it. Some privacy might be violated along the way, but it's okay. We're allowed to do that as a public health agency. We do it all the time. However, you do want to document what's going on. So, the better your notes are, the better you can document, like who it is you're talking to, what they said to you, why you've made the decisions you've made. The more notes you take, the better. But even that, don't let it get in the way of actually doing the work that you're doing. Okay, next slide. All right, so Section 3 is really the same as Section 2, but it's just a little bit more detailed. Okay, so the contact answers the telephone. You interview the contact, and the contact says, oh, could you please talk to this other person? That's fine. Talk to the other person. Or it might just be that the contact doesn't actually offer that information, but they just seem to you to be totally confused, and they're not following what's going on. They're not understanding what they're saying to you, and you might prompt them to put another person on the phone. And if they're willing to do that, then that's great. The person might be struggling with communication for whatever reason. Maybe English is not their first language. Maybe they don't have a high level of education. Maybe they, for whatever reason, maybe they have an intellectual or developmental disability, or they have dementia, or just whatever. And if they are able to put another person on the phone who's able to understand exactly what you're saying and speak to you clearly and directly and understand it all, then, great, because that will help you accomplish the work that you're doing. Okay, so the other person might actually not be there in the house with them, but you could get the other person's contact information and call the other person. As long as the contact has given you permission to do that, then that's a perfectly fine way to proceed, and you should do that. And as I've already said, when you're talking to somebody other than the contact, make sure that that person knows the contact's name, date of birth, and address, just as a minimal amount of due diligence to make sure that this person really does have a connection to the contact. Okay, next slide. Okay. Okay, bullet points number 1, 2, and 3, we've already gone through. It's really kind of repetitive and redundant, so I won't say it again. But now we're getting into this a little bit deeper, which is kind of like my third bullet point before, where the person is, where you're not getting permission from the contact, and the person you're talking to doesn't claim to be the healthcare proxy or anything of that sort. They're basically just saying, you don't need to talk to the contact, just talk to me. I'll talk to you. Just give me the information. I'll pass it along. You don't need to talk to the contact. Just talk to me, right? There's a lot of different reasons why the person might say that. It could be anything from they don't want the contact to talk to you. They might have some kind of cultural reason. They might have distrust of the government. They might have distrust of the contact themselves. They might want to know, oh, what has this contact been up to? Talk to me. You know, I'm their caretaker, although it really might not be their caretaker. Maybe the person's not their parent or legal guardian. It's their spouse. Maybe they're the parent of an adult child, and the parent of an adult child doesn't really have any legal authority over that adult child. However, as we all know, based on, life, a parent of a 19-year-old might still feel like that 19-year-old is a child and they're still the ones making the decisions. And in fact, they may be the one who's still making the decisions. Under our law, you turn into an adult the moment you have your 18th birthday, but we all know that 18, 19, or even, 27-year-olds don't necessarily act like adults. Sometimes they still act like children. So, there could be a lot of reasons, but the last bullet point, which is in red, is what we're going to be doing. And this is based on state law, it's based on HIPAA, and it's legal. So you can still go ahead and proceed with talking to this person other than the contact, even though they really don't have any legal authority to speak for the contact, if in your professional judgment, the person is an immediate family member, domestic partner, or close friend who should be involved in the contact's care. That is, use your common sense to make reasonable inferences of the contact's best interests and allowing a person to act on behalf of the contact. Now, some of you are probably scratching your head and saying, well, this rule isn't really a rule. That's so fuzzy. That's so amorphous. That's just, you're just telling me to make my own decisions. Yeah, that's right. That's exactly what I'm saying. Use your professional judgment, use your intelligence, and do the job that you've been hired to do, which is contact tracing. You're going to have to make some judgment calls, and that's okay. You can do it. Listen to the person's tone of voice. Listen to what they're saying to you. Get the information that you can get, and then make a judgment call, whether you can talk to this person or not. If you think it's okay, go ahead and talk to them. If you think it's not okay, don't talk to them. If you're not sure, talk to your supervisor. You're going to have difficult situations, and you're just thinking to yourself, well, maybe I should talk to this person, but I'm really not sure. I'm not comfortable with this. That's fine. Talk to your supervisor. That's why you have a supervisor. So, but what I don't want you to do is to say, there's an ironclad rule. It's the law. I'm not allowed to talk to this person. No, that's not the law. What we're allowed to do, what we're permitted to do, and what we really have an obligation to do as the state of New York is to protect the health and safety of people in New York. We have to do everything we can to prevent people from dying from coronavirus, and we're doing that work, and it's good work, and it's important, and we're going to do it to the best of our ability. So use your professional judgment. If you think it's okay to talk to the person, go ahead and talk to them. Okay, next slide. All right, so this is kind of a summary. If the person says it's okay to talk to somebody else or wants you to talk to somebody else, go ahead and do it. Sometimes you can have more than one person on the phone, and that's great. If the contact is on the phone and they say, can I put you on speaker? say yes. I mean, great. Then you're talking to more than one person. Involve the other people in the household. That's a good thing. You should do that. And like I said before, when you have these situations where it's a little bit unclear what to do, document what you're doing. Take notes. Write down what information you received. The more documentation you have, the better. Okay, next slide. All right, so this is kind of the flip side when the contact is a minor. Okay, next slide. So in general, minors can't consent to healthcare decisions. Minors can't, if you're a baby or if you're 5 years old, you can't consent to anything. Your parents speak for you. Your contacts could be of any age. So, if it's a young child, obviously you're going to talk to the parent or legal guardian. The young child is not going to pick up the phone, probably, although they might. But, obviously, if you have a 7-year-old on the phone, you're going to ask to speak to mommy, right? Because that's who talks for a 7-year-old. However, even though minors cannot make healthcare decisions, as I've already said like 10 times, this is not a healthcare decision. What we're doing here is public health work. So it's a little bit different. And in fact, as I already mentioned before, you're not a healthcare provider. What you are, believe it or not, is you're kind of like the police. We're exercising the police power, and we're protecting the health and safety of New Yorkers. So think about it. Can a child talk to a police officer? The answer is yes. And legally, it's the same thing. A child can talk to you. And so that's okay, because that's the type of work that we're doing. Okay, next slide. All right, so first bullet point is just a repeat. Second bullet point is just, obviously, whenever you, even if it's a mature 17-year-old, if the person's under 18, the first question is always, is your mother or father available? Could I please speak to them, right? Because that's just the default. When you do have, like an intact nuclear family situation, and the parent is right there at home and available to speak to you, then that's the default. That's the normal rule. You talk to the parents. So that's what you should do, even if the 17-year-old seems very intelligent and mature. So, okay, next slide. All right, so in the second bullet point, just for background, sometimes minors do make healthcare decisions. So, for example, minors can consent to diagnosis and treatment for STDs. They can also make certain other kinds of healthcare decisions. So it's not always the case that minors can't make decisions. Sometimes minors are emancipated. And as I already mentioned in the bottom there, it's okay for minors to talk to public officers, such as law enforcement officers. Okay, next slide. Okay, so the first bullet point is really talking about when in New York State a minor is considered emancipated for purposes of making healthcare decisions. So let's say the person is a minor, but they disclose to you, or for some reason you are aware of the fact that they are pregnant, they already have children of their own, or they're 16 or 17 and living independently from their parents or guardians. Under New York State law, such people can make healthcare decisions, and they can also do the lesser thing of talking to you as a contact tracer. So if they do fit into any of those categories, you should consider them adults. You should treat them like adults. Second bullet point is the slightly more ambiguous situation where they aren't legally entitled to be treated as adults, but they're acting like young adults, responsible, mature young adults. And many of our 16 and 17 or even 15 or 14-year-olds do act that way. So if the minor seems mature and appears to have the ability to make decisions, the ability to understand what you're saying and to act upon what you're saying, then again, you can use your professional judgment to determine whether the minor is mature enough to talk to you without the permission of their parents or legal guardians. So, it's the summer, and a lot of times kids are just, home and on their own recognizance all day. It's quite possible that mom and dad are at work or not home for whatever reason, and someone who's 15, 16, 17 picks up the phone. They're the contact, and you don't have anyone else to talk to. They're the ones who are presenting themselves and available and willing and able to talk to you. Well, if you think that that is going to further your job of contact tracing, go ahead and talk to them. Again, you can use your professional judgment, and if you think it's okay, then go ahead and do it. And if you're not sure, obviously, again, ask your supervisor. That's okay too. If you don't feel comfortable making these decisions, then talk to your supervisor about it. And I think that is the end. So now somebody is going to help me see what has come in through the chat box.
Hi, Jonathan. It's Vanessa Murphy. Can you hear me?
Yes, I can.
Okay. So there were some questions that came up about the difference between calling a contact up and talking to another person on behalf of that contact, and the fact that you can talk to that person and disclose information when you're talking to somebody who's speaking for that contact, versus, I think there's some confusion here, versus getting information in other contacts, other names of people, and then calling those contacts up and identifying the identity of the person that you got that information from. Does that make sense? I think there's some confusion there when you can reveal that information, and I think that when you're calling a contact up based on information that you previously received, I think that there is more of an emphasis on not disclosing that information, but I was just wondering if you could speak to that.
Yes, the answer is that in that case, is that you should not disclose that information. So I'll give you an example from, since the late 1980s, we've been doing our darndest to end the AIDS epidemic. So the AIDS Institute here in the New York State Department of Health also does the work of contact tracing. They've been doing it for decades. And so what will often happen is you talk to a contact and you say, we have reason to believe that you may have been exposed to HIV. You really need to get tested. And, in that situation, people are going to want to know, well, why? Who'd I get it from? What's your information? What are you saying? Tell me, right? And the answer is we don't tell them. We don't tell them, why we think they are a contact. Well, we might say it in a general way, but we don't identify specific people who perhaps gave them the disease. Now, sometimes it's very obvious because, like in the case of HIV, that's a sexually transmitted disease. You can also get it through sharing needles, but the average person doesn't, take intravenous drugs. So in a lot of cases, the person has only had one intimate sexual contact. And so they know that that's the person that may have given them HIV. They can instantly figure that out. But we still don't say the name of that person, right? So so the answer to that question is no. You don't name the people from whom they may have gotten coronavirus. That is something that you keep confidential. You just talk about it in a general way, even though it's quite possible when you do start talking about it in a general way, like, oh, you did this, or you went there, or we heard you were at this place, or whatever, they might very quickly be able to figure it out who they possibly got it from. But if they can figure it out, they can figure it out. That's okay. But you don't name the person.
Thank you, Jonathan. Sort of relatedly in terms of, who you can give information to, there's a question that came up about how you can use information that you gain as a contact tracer in your personal capacity. The scenario given was, a neighbor is COVID positive. Do you give a heads up to the other neighbors who frequent each other's homes that there's a positive person in the neighborhood without disclosing their identity? And just what your thoughts are on perhaps using some of the information that a contact tracer may have gained through their professional capacity and using it in a personal capacity.
So the answer is no. Don't ever use the information in your personal life. Never. Don't do it. If you somehow come upon information that might be relevant to the work that the Department of Health is doing, then you can disclose that within the Department of Health, and then the Department of Health might, put the neighbors down as contacts, and then they would be contacted by contact tracers. Right? So you could report that within the Department of Health, but no, don't take it upon yourself to use any of this information, and take it into your personal life. Don't do that.
Another question that came up was, a lot of times contact tracers run into situations where people express to them that they feel that their HIPAA laws are being violated by the questions that the contact tracers are asking. So this person is just asking if there's anything that would be easy to say or the best way to tell them that they're not a covered entity to explain to the contact that they're interviewing.
Yeah, I think that what you want to do is not be argumentative and not be confrontational. So I think what you should do is be empathetic and say, yes, confidentiality is really important. We're doing everything possible to protect confidentiality. We know that that's very important. We're following all applicable federal and state laws, including HIPAA, and we're doing everything possible to protect confidentiality. However, there's a global pandemic and people are dying, and we're also doing everything possible to try to, prevent people from getting sick and dying, and this is how we're doing it.
Thank you, Jonathan. A lot of questions have come up about contact tracers when they're not able to speak to the contact and they're speaking to others on behalf of the contact, where they're not able to verify all the information that you recommended, like the individual's not able to verify the date of birth, and they're just wondering how they proceed under those circumstances.
Okay, well, we'll get back to you on that. Up until now, we've created a rule that that the person you're talking to should be able to identify the contact's name, address, and date of birth. So, unless you hear differently, that's the rule. But we'll think about it some more.
And this is Delia. Can I just quickly add, in those cases, the contact tracer can escalate that to their supervisor if there's any concern about the veracity of information that is available or not available, or there's not enough information available.
Yeah, I like that. I like that. I like what Delia just said. So yes, as a contact tracer, don't proceed unless the person can say the name, address, and date of birth. However, if you think that you should be talking to this person, you can let the supervisor make the call.
Thanks, Jonathan. Delia, that's all the questions that I had summarized. I don't know if you have any additional.
I do. One second. Did we talk about the language access line at all? I don't think we did. All right, so this question came up a few times, Jonathan. It's the question, so kind of the best practice, obviously, is to use the language access line if the contact does not speak English and the contact tracer does not speak the language that the contact speaks. But there is the questions about, many people informally having their children speak for them if they, if for their non-English speaking parents. And what are your, do you have anything additional to add about these situations? Is there any?
Yeah, sure. So I think you should make a judgment call. You're going to have some cases where nobody in the household speaks English or nobody who's available speaks English, and then you have to use the language line. And you certainly, always can have the language line that's available to you, but there are going to be situations where it's easier for everybody and just more effective to just let the child speak for the parent. And, that doesn't mean that the child is making decisions for the parent. In a lot of these cases, it's just the child is literally just acting as an interpreter. Again, I would just say it's a case where you have to use your judgment. In some cases, that's just going to be more effective to let the child act as the interpreter. And if that works, it works. Go ahead and do it. You don't have to use the language line if there is an expert on interpreting for the parent right there in the household. And I'm sure that in many cases, children do become, expert interpreters for their immigrant parents.
Thank you. And then just one last piece of information I wanted to pass on, not a question necessarily, and you touched on this, Jonathan, that if a contact tracer knows a contact, they should not complete that interview. They should pass that on to another contact tracer, raise it with their supervisor, but they should not be interviewing contacts that they know or are acquainted with. So I just wanted to reinforce that idea.
Right, that's a good point. So it's, it just follows the general principle that, you really want to create a, quote, Chinese wall, like the Great Wall of China, between your job and your personal life. You just don't mix the two. Don't mix business and personal.
Yeah, so I don't have, Vanessa, did you see any other additional questions that have come in since Jonathan started answering them? That
a lot of them are similar, but we can go through them and group them by topic and try to provide answers to anything that we haven't answered. Okay.
Yes, we will do that, and we will post the responses to the common themes on the CT support website. So thank you very much, Jonathan, and thank you for Vanessa, and thank you to all the participants who submitted questions and ideas and suggestions. Everybody have a great day.
Okay, bye-bye. Thank you.
Ladies and gentlemen, that does conclude our conference for today. Thank you all for participating, and you may now disconnect. Have a great day. Presenters, please stand by.